Today, we are reviewing neonatal complications, some of the highest yield topics you'll see on NCLEX. The exam wants you to quickly recognize what is normal, what is not normal, and most importantly, what you do next to protect the newborn. We'll move through respiratory problems, metabolic and gastrointestinal issues, infections, withdrawal syndromes, and congenital disorders. Along the way, I'll highlight the high-yield points so you can lock them in. Let's start with respiratory distress syndrome, or RDS. This condition is caused by prematurity and a lack of surfactant, the substance that keeps the alveoli open. Without it, the alveoli collapse and the baby struggles to oxygenate. Typically, the newborn may breathe normally at first, but soon develops labored breathing, cyanosis, grunting, nasal flaring, retractions, and tachypnea greater than 60 breaths per minute. Severe cases can progress to apnea and unresponsiveness. Diagnostic testing includes amniocentesis for the lecithin to sphingomyelin ratio to measure lung maturity, ultrasound of biparietal diameter, and blood gases that show low oxygen and high carbon dioxide. Nursing care for RDS means maintaining a neutral thermal environment, avoiding oral feeds during the acute phase, providing parenteral nutrition and IV fluids, and suctioning as needed to keep the airway clear. Positioning can be side-lying with head support or supine with a slight neck extension. Respiratory support may include CPAP, PEEP, or mechanical ventilation, and in severe cases, high-frequency ventilation may be needed. Surfactant replacement therapy is the cornerstone of treatment. The key point to remember is that RDS equals respiratory distress from surfactant deficiency. Another major respiratory complication is perinatal asphyxia, which is oxygen deprivation around the time of delivery. Watch for meconium-stained fluid in a non-breech baby, abnormal respirations, cyanosis, bradycardia, seizures, or bulging fontanelles from intracranial pressure. The immediate priority is always the airway. Suction if meconium is present, and provide ventilatory support with bag mask ventilation, intubation, or mechanical ventilation as needed. The NCLEX hook here is simple. Perinatal asphyxia means airway first, then ventilation. Cold stress is another condition to know. Newborns cannot shiver. Instead, they rely on non-shivering thermogenesis, which burns up oxygen and glucose. Signs include mottled or cyanotic skin, metabolic acidosis, hypoxia, and hypoglycemia. It may be caused by hypoxemia, central nervous system injury, or low blood glucose. The interventions are straightforward. Warm and dry the baby immediately after birth, place them in a neutral thermal environment like an incubator or radiant warmer, keep a fabric cap on the head, and use skin to skin with the mother. The key phrase to remember is cold stress means the baby is consuming oxygen and glucose just to stay warm. Now let's turn to metabolic disorders, beginning with hypoglycemia. Normal newborn glucose is 40 to 80, and hypoglycemia is less than 35. Signs include jitteriness, irregular respirations, cyanosis, a high-pitched cry, lethargy, twitching, seizures, and sometimes eye rolling. At-risk infants include babies of diabetic mothers and those who are small or large for gestational age. Nursing care involves checking blood glucose soon after birth and repeating at 4 hours, feeding promptly if the infant is not lethargic, and giving oral or IV glucose if needed. Avoid rapid overcorrection because that can cause rebound hypoglycemia. High yield. A jittery or seizing newborn should make you think hypoglycemia. Hyperbilirubinemia is another common complication. There are 4 types. Physiologic jaundice appears after 24 hours, peaks at 72, and resolves within a week as the liver matures. Breastfeeding jaundice occurs in the first few days from poor intake and dehydration, and is managed with more frequent feeds or supplementation. Breast milk jaundice appears at 4 to 5 days and is due to a factor in breast milk that slows bilirubin metabolism. This resolves if breastfeeding is stopped for 24 hours. Pathologic jaundice is the most serious and always abnormal. It appears in the first 24 hours, often due to hemolysis, and requires phototherapy or even exchange transfusion. During phototherapy, the infant's eyes and genitals must be protected, fluids should be increased to prevent dehydration, and bonding should be supported. The NCLEX hook is that jaundice in the first 24 hours is always pathologic. Closely related is hemolytic disease of the newborn, most often due to Rh incompatibility. This happens when an Rh-negative mother develops antibodies against the Rh-positive blood of her baby. The baby shows jaundice in the first day of life, anemia, and a positive Coombs test. Treatment includes close monitoring, phototherapy, and exchange transfusion if severe. The high-yield phrase is Rh-negative mother with an Rh-positive baby leads to antibody attack on red blood cells. Now let's review necrotizing enterocolitis, or NEC. This occurs when an immature gut experiences ischemia and bacterial overgrowth, leading to necrosis. Signs include feeding intolerance, bile-stained vomiting, abdominal distension, bloody stools, temperature instability, and lethargy. It typically develops 4 to 10 days after feedings are initiated. The hallmark diagnostic sign is an abdominal X-ray showing air in the bowel wall. Care involves stopping feedings, decompressing with a nasogastric tube, giving IV fluids and antibiotics, handling the infant very gently, and maintaining strict hand hygiene. Nutrition is provided parenterally until the bowel heals. The phrase to remember is NEC means necrotic bowel after feeds. Infectious complications include neonatal sepsis. Unlike adults, neonates often present with hypothermia instead of fever. Other findings include poor sucking, vomiting, diarrhea, lethargy, apnea, seizures, weight loss, and dehydration. Risk factors include prematurity, maternal group B strep, prolonged rupture of membranes, or invasive procedures during birth. Treatment involves antibiotics for 7 to 10 days, oxygen therapy, stopping oral feedings, and sometimes transfusions or IV gamma globulin to boost immunity. The high-yield takeaway is a cold baby rather than a hot baby should make you suspect sepsis. Neonatal abstinence syndrome, or NAS, results from intrauterine narcotic exposure. Symptoms include a high-pitched cry, tremors, hyperreflexia, poor sleep, tachypnea, sweating, frequent sneezing or yawning, and non-nutritive sucking. These can appear in the first day or up to a week later. Nursing care involves monitoring tone and vitals, giving medications such as phenobarbital or methadone if prescribed, reducing environmental stimulation with dim lights and quiet surroundings, offering pacifiers, feeding frequently, swaddling snugly, and supporting parent-infant bonding. The NCLEX hook stands for not a silent baby. Finally, let's talk about cleft lip and cleft palate. Cleft lip is a fissure of the upper lip, while cleft palate is an opening in the hard or soft palate. Lip repairs are usually done between 1 and 3 months of age, and palate repairs between 12 and 18 months before speech develops. Preoperatively, support parents emotionally and provide feeding devices such as special nipples or cups, feeding slowly with frequent burping. Postoperatively, the goal is to protect the suture line. Use a Logan bow or tape, clean with saline, and apply antibiotic ointment. Position the infant on the unaffected side, and minimize crying. Elbow restraints may be used to prevent touching the surgical site. Long-term care often includes speech therapy and orthodontics. The NCLEX hook is that cleft means careful feeding and careful protection of sutures. That completes our review of neonatal complications. To summarize, respiratory problems always begin with airway first. Metabolic issues center on glucose and bilirubin stability. Gastrointestinal emergencies like NEC occur after feeds. Infections often present with a cold baby. Withdrawal babies are never silent. And congenital anomalies like cleft lip and palate require careful feeding and surgical protection. If you can recognize these patterns quickly, you'll be ready to answer NCLEX questions with confidence. And, more importantly, keep newborns safe.